second day of the European Society of Intensive Care Medicine's WebTV. Welcome. Today we have for you an experts discussion about the recent article in the Lancet Journal on the current and future status of intensive care medicine. Selected abstracts on acute respiratory failure, stem cell therapy in the ICU, health services, research and organization, infection, and in the context of the LIFE campaign, a discussion on the outcome of CPR. And finally, we have intensivists reading the letters of their patients. Stay tuned.
I'm in the TV studio with Randall Curtis from Seattle, USA, Gordon Rubenfeld, Toronto, Canada, and Mervyn Singer from London. They all published in the Saturday issue of the Lancet, just at the beginning of this Congress, a major piece on critical care. Could you summarize for us the main message of your paper, Randy?
Sure. My paper was on ethics and end-of-life care in the ICU. The ICU takes care of the sickest patients, and ethical issues come up frequently. There's a lot of variability around the world in how intensive care units are utilized, what patients are admitted to the ICU, and when ICU care is either withheld or withdrawn. And a lot of that variability has to do with culture and religion of patients and their families, but also of the physicians. And what we really looked at was how, although there is this variability, and some variability is appropriate, that the underlying principles, ethical principles, should generally be the same. And that there are certain situations where the variability is more than should be driven by culture and religion alone. And is really in part because we don't have a good understanding of how to apply these basic ethical principles in the ICU setting. And we need more education, and we need more sort of global discussions about these issues.
Gordon, you're one of our most talented epidemiologists. What is the main message of your paper?
Well, our team tried to look at the burden of critical illness and intensive care around the world. This work led by Neil Adhikari in Toronto. I think one of the most important things we found, John Danielle, is just how hard it is to figure out what is an intensive care bed, what is critical illness, and try to put together numbers that make sense from around the world. For example, how can we possibly estimate the burden of critical illness in Africa? I mean, these are data for sure. There are many critically ill patients, but these data just don't exist. You can go to a website for the World Health Organization and pull down the number of people who die from cancer or severe infection or car crashes in any country in the world. And we all know at this meeting that many of those patients are critically ill before they die, but those data just can't be found. So I think the important message from our paper is the burden of critical illness is likely to be extremely high, and it's going to increase as our population ages and as there are more and more, unfortunately, financial strife, not to mention pandemic illnesses around the world. It's likely that the burden will increase.
So Mervyn, you are known for thinking outside the box and inside the mitochondria. So,
well, the article I wrote with Jean-Louis Vincent was very much looking at the past, the present, and the future of critical care. And I think the conclusion we came to is that we're evolving as a specialty, we're maturing. And so, whereas beforehand it was the ability to make numbers look normal, we've appreciated that perhaps these efforts to make the numbers look normal is often to the detriment of the patient. And so we need to embrace and understand the pathophysiology far better to see how that impacts upon the patient. And clearly, looking forward, there's a need for new technologies, better diagnostics to guide how we individualize care. So therefore, we have to move away perhaps from population-based treatments to encompass the individual as well.
Thank you all for this major contribution to our discipline.
You're welcome.
Acute respiratory failure is a major issue in the ICU. Today, we have two professors who have selected 3 abstracts that will tell us what's new in the horizon. So, Professor Larsen, could you please tell us which is the first abstract you've selected?
I have selected an abstract by Curley and co-workers from Ireland, and they show that mesenchymal stem cells enhance repair after ventilator-induced lung injury in mice. and it shows that it also reduces inflammation and induce water content in the lung. And we have a problem in the ICU with ALS patient, and this is a promising new treatment that I think will have a future.
Professor Conti, what is the second choice?
Yeah, I selected the study by Ali and co-workers. It's a multi-center randomized prospective trial addressing the use of the use of steroids in patients with COPD exacerbation requiring mechanical ventilation. We have a lot of study already on steroids in COPD exacerbation, but not in this specific subset of patients. And this study shows quite clearly that a 10 days course of steroids can reduce the need for mechanical ventilation and the length of stay in ICU. And this is quite evident, above all, in the subset of patients requiring non-invasive ventilation.
And the third choice, Professor Larson?
I chose a study by Ciomelli that they have investigated patients in the study of prone positioning. Prone position has been suggested that will cause neuromuscular dysfunction after the treatment, but this study shows that this has no problem neuromuscular function. They have good quality of life, and they come back to a good life after this treatment, and it's as good as using the ordinary supine position.
Thank you very much.
Thank you.
Thank you.
We have with us Professor Jordi Rello, who will discuss what's new in the front of infections. So, Professor Rello, tell us, what have you selected for the new studies?
Well, they are an abstract from Martin Loeches that is a very important study because it was a collaborative study involving coordinators from many countries reporting what is important in the past influenza pandemic. And one of the key questions was how to improve survival in these patients. So it was analyzed if any inflammatories administered to these patients were improving survival. Now, we learned that it was not possible to improve survival with use of steroid therapy, and this patient developed more superinfections and more days in the ICU. So this is an important contribution to improve management of these patients.
In today's world, where financial restrictions are abundant, health services research and outcome is a major issue. So, Professor Capuzzo, could you please share with us your selections?
The first selection is on patients ICU admitted with or without pre-existing diabetes. And the main results are, the first one is that the mortality of patients with diabetes is higher, both at short time and at long time, than that of non-diabetic patients. The second point is that the patients receiving metformin as a treatment before ICU admission had a mortality which was similar to that of non-diabetic patients. The second study was on patients admitted to ICU with cancer and or hematologic malignancies and admitted with septic shock.
I think there are two interesting aspects. The one is that there is a general trend in treating oncological patients also in ICUs and that they deserve such a treatment. And the second one, as you mentioned, the volume effect. The more you treat patients, the more you're experienced, of course, in these patients.
Stem cell therapy, an amazing area of research. But where do we stand now? We have with us Professor Menage and Dr. Cobb, who are going to discuss with us the status of the therapy today. Dr. Cobb, you're the director of the Multiple Organ Reanimation and Regeneration Program at the Massachusetts General Hospital in Boston. Can you please tell us what are the goals of this program?
Of course, Antonios. So as I mentioned, the use of stem cells in regenerative medicine for critically ill patients is quite new. There's been a decade or more of very exciting, very provocative results that have been reported in animal models, and we think it's important to move it to patient studies. So we're pursuing multiple organ reanimation and regeneration specifically to create a better bridge between engineers and biomedical researchers for systems engineering and for also cellular and tissue engineering.
Please tell us, where do we stand in stem cell therapy of heart failure?
We stand at the end of the first wave of clinical trials. I think there has been much hype about that. The results are either negative or only show marginal benefits, but we now have a bulk of data which could and should serve as a building block for preparing the next generation of both experimental and clinical studies.
Can you tell us what is new about stem cell therapy in sepsis?
There are numerous studies that have been conducted in animal models looking at the treatment of mesenchymal stem cells, sometimes called mesenchymal stromal cells, for the treatment of organ dysfunction. And those studies have been quite provocative and very positive in their effects in improving organ dysfunction and also improving survival.
You have hundreds of patients now who've been treated with stem cells for heart failure either during surgery or by catheters. But as I was just mentioning, if you do not consider the small, non-controlled and then randomized studies, but just focus on the randomized controlled trials, the benefits are either very limited or even absent. And that's not really unexpected because this is a new therapy and we still have a lot of things to learn before we make it fully effective.
Thank you very much both for being with us.
Thank you, Antonio.
Thank you very much.
In the context of the LIFE campaign, free CPR lessons were offered to the public in Barcelona. People were taught how to provide CPR if an emergency occurs. We have Dr. Jerry Nolan here, who's going to discuss these questions with us.
I think that there is no doubt that increasing bystander CPR rates will have a dramatic effect on outcome from out-of-hospital cardiac arrest. It's generally reckoned that bystander CPR will at least double the chances of somebody surviving from out-of-hospital cardiac arrest. So I'm delighted to hear that the LIFE campaign has been undertaking that training and would encourage more training if at all possible.
It's been great. It's especially, so spontaneous here, just out in the street. It's usually always linked to work or you have to sign up for it especially. And it's just been really, really nice to see that, it's done this way and taught this way to citizens and that people can have such easy access to the knowledge.
I think the question of compression-only CPR is a very hot topic at the moment. There is quite a lot of evidence to suggest that if somebody has a sudden a collapse outside hospital, so a cardiac arrest of cardiac etiology, and particularly where response times are going to be reasonably quick, it would seem that if a bystander just does chest compressions only, instead of attempting to add in mouth-to-mouth ventilation, it's possible that those outcomes are at least as good and in some circumstances even better than conventional CPR. So the question is, should we be training the lay people to do full standard CPR to include mouth-to-mouth ventilation, or should we teach them to simply do chest compressions only?
Dear ICU team, I'm writing on behalf of Sam to say an especially big thank you from Sam and all the family for the absolutely wonderful care that you all took of him during his short stay with you over the Christmas period. So thank you. We are all immensely in your debt for the way that you dealt with Sam and took care of him through what was a particularly traumatic period for all of us. We actually can't thank you enough for the exceptional kindness and care that you showed. To be honest, I'm completely bowled over by it. We also know only too well that without the dedication and professionalism displayed by everyone in the ward, we would, in all likelihood, have lost Sam. The fact that he was able to come home after just a few days and begin a slightly delayed Christmas was the best present that any of us could ever have dared hope for. So far, Sam's progress has been excellent, with no recurrence of the fits whatsoever, although, of course, we remain open to the reality that this may happen again. It is perhaps because of the phenomenal care, coupled with the clear, unambiguous, straight talking that we received from adult ICU, that we were left feeling somewhat in limbo when it was contrasted with our subsequent experience of the pediatric unit. My meeting as a governor of Sam's formal special needs school is to try and achieve a positive outcome in the way that the rest of the hospital understands and deal with people such as Sam, especially those on the cusp of adulthood. In doing so, we hope that they will be more able to emulate the outstanding standards of care and professionalism set by the adult ICU team. We shall be always grateful to each and every one of you. Thank you for giving Sam back to us safely. Bless you all. Very kindest regards.